Welcome back to the Digital Health Hubcast. I'm your host, Hannah Clemens, and today we're diving into one of the most urgent and complex global health challenges, antimicrobial resistance. It's a silent pandemic that threatens to undermine decades of progress and force a return to the pre-antibiotic era. Antimicrobial resistance isn't just a problem for hospitals, it's in our farms, our food, our water systems, and the environment around us, and affects everything from soil health to public sanitation. To explore this, I'm joined by Davey Jones, a Professor of Environmental Science and Public Health at Bangor University and the Deputy Director of the Digital Health Hub for Antimicrobial Resistance. He has expertise in understanding the behaviour and fate of microbial pathogens and antimicrobial resistance in wastewater systems, and the use of wastewater-based epidemiology for public and environmental health surveillance. Welcome, Davey Jones, to the Digital Health Hubcast.
Hey, pleased to be here.
Great. Tell me a little bit more about yourself, Davey.
So, as you'll see from the picture behind me, it's a picture of a wastewater treatment plant. Some people might not say that's a glamorous business, but what we do is we're based in Environmental Centre Wales at Bangor University and part of the AMR Digital Health Hub. And what we are basically doing is trying to provide using wastewater basically to provide an early warning system for various diseases. So, everybody uses the toilet, and as part of that process, you're shedding, pathogens and markers of health all the time into the sewage system. And instead of going around and testing everybody in the neighbourhood, which would be very time-consuming, labour-intensive, and ethically not compliant, we basically go to the wastewater treatment plant, collect the effluent from 10,000, 100,000 people or whatever, different places, different sizes. And we analyse what's in there, and then that tells us about the health of the community. So it's one of the really cheap, unbiased ways to assess community health, which has not really been done previously. So we're bringing that sort of environmental side of things to classically what you would consider to be a clinical or a medical problem. So.
Yeah, absolutely. And this problem we're talking about is antimicrobial resistance. So I wonder if we can start by just defining that a little bit and exploring why this is such a huge problem, such a huge challenge.
Yeah, I mean, I think most people probably are aware of the issue of antibiotic use. Even if you read the side of a packet, it says, make sure you take the full course of antibiotics. So subliminally, you're getting messaging about antibiotic usage all the time. And what we've learned really is that, over the years, we're in this constant warfare really with the bugs that are trying to take over our bodies. Many of the microbes that we have live inside us in our guts, on our skin and what have you, and in our lungs, for example. Many of those are beneficial, but occasionally they can be pathogenic and they can be, cause diseases which, if left untreated, could be incredibly serious and could lead to death. So what we're trying to do constantly is generate new antibiotics to try and fight these infections. But, even though microbes you can't see with the naked eye, they're incredibly small. They're constantly fighting back, evolving. So that's why I say it's almost like trench warfare, so it's like they're constantly trying to evolve new mechanisms, new strategies to overcome the antibiotics that we keep trying to throw at them to control them. So, when you take an antibiotic, for example, orally, for example, or intravenously, that targets microorganisms, particularly bacteria, mainly, punches holes in their membranes sometimes. And that basically kills them, and then we can the immune system can then kick in and take over and suppress the rest of the infection. But the problem we have is that these microbes are they're not intelligent life forms, but they evolve, and they're constantly deciding well, if we're going to survive, we need to adapt, and to adapt they have various mechanisms, which means that they can take genes from other organisms. So they'll say, oh, quite fancy that one because that, basically confers resistance. So they'll take in various things, DNA from the outside of the environment, and they'll put it into their own cell, and then they'll use that, and they'll basically test out all the time whether these things give them a competitive advantage. And some of those genes provide antibiotic resistance, which means that when you add give somebody antibiotics, they don't work anymore. So, and what we've seen over time is that, as we introduce more antibiotics into clinical health, gradually the microorganisms are constantly, evolving and getting, defense systems so that they don't get killed off. And, it's this, so we're constantly trying to stay one step ahead in antibiotic design, trying to find new ones all the time, which is becoming increasingly difficult. I think I would say, I call it a slow burner because, the fast burner is, for example, when you get an infection from Salmonella or Campylobacter norovirus, you get that through food or from fecal oral transmission in the workplace or whatever. You ingest those organisms, they give you diarrhea and vomiting, and it's literally within 24, 48 hours or whatever, you get the symptoms. So you contract the disease, the symptoms are there, you treat them, and we move on. With antimicrobial resistance, it's a much slower thing. So you can come into contact with these organisms, harbour them within your gut, for example, or on your skin. But it's only several years later, when you want to be treated with antibiotics, that you realise that you've now got these resistant organisms in you. You have no idea where they came from. I mean, they could come from anywhere, from touching surfaces, from ingesting water, from going swimming, from friends and family, from your pets. It may be years later, it may be decades later. And that's the problem we have really, is that, it's quite hard to control because it's not an obvious thing. Like you get a virus, COVID, and you get the symptoms within a week. This is something that you contract and then maybe don't experience it for years later.
So you mean that they can lay dormant kind of in your body, on your skin for some time? Is that what you mean? Exactly.
So, there's a fungus now, Candida auris. So most people are, I may have heard of, yeast infections and things, Candida albicans and what have you, but a different type of yeast which is spreading around the world now, Candida auris. Once you get that on your skin, for example, you can't get rid of it ever. But you'll never know it's there because it won't cause you any problems until you, for example, have, say you had surgery or something, and then suddenly, you get that in the bloodstream, and then it causes the equivalent sepsis essentially, and can cause death. And that's the same with many of the organisms that we have. If you have intestinal surgery or something. And you've got these organisms in the gut or wherever in the body, and they're opportunistic. So they lay dormant for many years, and then they go, oh, here we go. This is it. We're in.
The moment, yeah.
Yeah, the moment's happened, yeah, that we've all been waiting for, they say. And off they go, infect, of course, sepsis, and the outcome could be really bad if you can't treat it with antibiotics, obviously. And those cases are increasing all the time.
Yeah. So the problem, obviously, for humans is really stark. We might go back to a pre-antibiotic era if we sort of lose all of the, if so many bugs become resistant and we're struggling to build more antibiotics. So that's really clear. And the problem isn't just humans using antibiotics, is it? There's lots of other uses of antibiotics in agriculture, in farms, in other places. Can you speak on that a little bit?
Yeah, I think there's some things that we are becoming more aware of. Obviously, for veterinary medicine, treating animals who are sick is really important. I think there was a culture in the past really of having sort of almost like preventative medicine. So you would give antibiotics to animals even if they weren't showing signs of infection. But all that has caused is the more rapid evolution of these antimicrobial resistant organisms. We also give a lot of antimicrobials to pets, obviously, take them to the vets when they're sick, and they'll prescribe them. And same thing if often dentists will prescribe them as well. It's not always in health, the classic healthcare settings that we think of. And what we've realized now is that the antimicrobial, you say you give an antibiotic to a dog, and that may trigger antimicrobial resistant organisms to be created inside the dog. And because we're in close contact with those pets and dogs all the time, then we contract that microbiome from the dog. I mean, many people don't like to think about having a shared microbiome with their pets, but I can guarantee you, that is the case. And we've seen that with farmers, for example, where we've been testing antibody levels and in farmers, because they tell you that their cows don't contain pathogens, for example, but when you take blood samples from them, you can clearly see that they've been exposed to quite a lot of pathogenic organisms at really low levels. So they've developed immunity to it. So they don't know that they've been infected, but they have, and they're now carrying, in some cases, they're now asymptomatically carrying these pathogens around with them, which is quite interesting, really.
And it's not so much a problem anymore, because I think the EU banned kind of giving antibiotics as growth promoters some time ago. Is that the same for everywhere, or is this still a practice that's used? So giving antibiotics in the feed just to help animals grow bigger?
Not that I know of,
yeah.
But that doesn't mean to say it doesn't happen.
Okay.
Because I don't work in the chicken feed industry. Sure. It could well be still happening, but I wouldn't like to comment on it. One thing we do know, though, is that these antimicrobial resistant organisms, they exist in pet food, for example. So I think it's quite an interesting debate at the moment about there's this sort of move towards feeding dogs on raw food rather than cooked food. And the raw food contains, lots of antimicrobial resistant organisms, which are promoting the spread of this within pets and then to us. So, so that the advice really is to move not to give raw food to your dogs, because we know that that's a risk factor. But I think that's a difficult message to convey to people, because the links are. There's several steps before it comes back to us to haunt us, really.
Gosh, yeah, I wouldn't think of that. I see those adverts all the time, for raw cat food, raw dog food. And I suppose it's the process of cooking then that will kill those bacteria. So there's less of a risk. Is that what you mean? It's the being raw is the problem.
Yeah. I mean, absolutely. When I'm teaching my undergraduate students on sort of risk management and pathogens and what have you in the environment, I say, there's a good reason that we harness the power of fire, to warm things up, including ourselves, but to cook food properly so that we don't contract pathogens, because if you take a fish from the wild, for example, people, have raw sushi, but inside, if you eat just a raw fish, say you pull one out of a river here and you ate it, it would contain all sorts of parasitic worms, which can go into us. So, but obviously, if you cook them, you kill all those things off. We know from oysters, for example, that lots of people get sick from eating raw oysters. But if we cooked them, we wouldn't get sick. So because we would kill the pathogenic viruses in there. Yeah. So I can see the point of feeding a dog raw food, because it seems more natural. But yeah, it's not. I don't think it's helping really the fight against antimicrobial resistance.
So let's talk a little bit more then about the One Health approach. So tell me what this means in terms of tackling the challenge of antimicrobial resistance.
Yeah, I mean, I must say the phrase One Health is a little challenging for most people because it's not an obvious term. But, it's been taken on by the World Health Organization and others. And what it means is that we now realize, as sort of described in some ways, there's a link between what we do, what the animals do in the environment, and the environment itself. So there's an interconnectedness. So, a few examples might be, we go to the toilet, we defecate into the toilet, or we have a UTI. The organisms associated with that, urinary tract infections or whatever, they go to the sewage treatment plant. We assume that they're all treated and killed off, and that's the end of it. But that isn't the case, obviously, as we know from all these reports of raw sewage dumping into rivers and oceans around the UK. So the raw sewage goes out into the environment, and it contains those antimicrobial resistant organisms that we had. They're now floating around, and there's otters and seals and all sorts of things swimming around in this sewagey soup, and they contract some of these things, and so they perpetuate the spread of these antimicrobial resistant organisms. They transport them from different places. Sometimes they come back if they're if obviously they're a food source, they come back into the food chain. But also, we're also, some of the things that we do, we don't really think are a risk. So when we take an antibiotic, we think that's a good thing. It's a good thing for us. Kill off the organism. Let's get back to business as usual. But we put the antibiotics down. We consume them. A lot of those antibiotics go straight through the urinary system, out into the sewer, and then inside the sewer, you've got these pipes that are running all. For every road you have in the UK, you have a sewer that runs underneath it. So there's millions of kilometers of this stuff. And the organisms that live in those pipes are being exposed to antibiotics, and they're developing resistance within the pipes. And then they're multiplying, and then they're going off down the sewer system, and the same thing back to the environment, infecting. Cows are drinking the water, or sheep or whatever other domesticated animals. They're now getting these antimicrobial resistance within the domesticated animals. We try and treat them, it doesn't work. The same thing for us, really. We treat animals with antibiotics. They become resistant within the cow or the sheep. Those organisms come out the back end of the cow. They go into the water courses, or they're on, in fields where people are around, and then we contract them. So there's I think, from bird flu, for viruses, we know there's, and from SARS-CoV-2, for example, there's this link with viruses between humans and animals. The same thing exists for antimicrobial resistance. It's like, it's a constant cycle of these sort of organisms. And then I think one of the things that people don't realize is that, a lot of the antibiotics that we use come from soil. So, soil, a handful of soil contains, like 1 billion organisms, 1 billion bacteria, for example. And they're all fighting with each other as well, because they all want to be the top bacteria, as it were, and multiply. So to kill off their neighbors, they're releasing antibiotics into the soil all the time. So, way back when, we realized that, when you put two bacteria together from different species, one kills off the other. And so that's how we sort of discovered a lot of these antibiotics, harnessed the power of them. Some of them are antifungal, some of them are antibacterial. So in the environment, there's this massive reservoir of antimicrobial resistance anyway. It's a natural thing. So people think that it's completely man-made. Some of it may be to synthetic antimicrobials that we generate, but most of it is natural. It's just that we're accelerating the resistance within the environment, I suppose, through our actions. But yeah, this thing is a natural process. Bugs like to kill each other off.
I guess it's only such a problem now because the bugs are starting to kill us, and we're losing the power to fight back, as it were.
That's right. Yeah, we don't mind if they fight each other in the soil and in the field. They can stay there and do that. But yeah, it's when it starts impacting on us we have a problem.
Yeah. Tell me a little bit more then about the options that we have to combat this antimicrobial resistance. It seems like there's obviously it's in a lot of different places, so there will be people with a lot of different competing interests. So the farmers have a reason to give their animals antibiotics. Same for in hospitals and that sort of thing. So tell me about how are we starting to kind of solve this problem?
Yeah, I mean, this is the $1 million question, of course. If it was easy to solve, we would have solved it. And classically, with a very complicated problem, it requires a very complicated, multifaceted approach. So lots of ways to try and tackle it and try and solve it. Some of it is about a better understanding of the fundamental biology. Why, how frequently do organisms transfer genes to each other? What conditions in the human gut or in the environment stimulate, microbes to take on these resistance genes? In particular, there's certain opportunistic pathogens that we have, Pseudomonas, other things, that, E. coli. Understand still, you'd think after all this time we'd understand that fundamental biology, but there's still loads to learn. So I think there's that. It's understanding the fundamentals of life is critical. There's also, about what we call antibiotic stewardship, using antibiotics better in a more targeted approach. There's lots of evidence to suggest that, for example, people will go to the GP surgery with a cough or cold or something, and they'll try and wheedle antibiotics out of the GP when clearly they've got a viral infection. I think part of this stems to some extent because we don't have good on-site viral testing. Mm-hmm. So consequently, if we had that, we'd say you have a virus. You have RSV, you have flu A, you have rhinovirus, for example. But we don't have that on site. We have to send the samples away, and by that time it's too late. So that people want to leave with something, whether it be the placebo effect or something. Sometimes they get better, but we're trying to stop people giving antibiotics out when there's no reason. So if we can, we use lower doses. It's a nuanced debate about whether we should have shorter doses. Or whether you should stop taking them once the symptoms start to subside, or whether you should take the full course. At the moment, we're still, I think a belt and braces approach is still to take the full course of antibiotics. But I know that there's a sort of some people out there are thinking, that's just exacerbating the problem to some extent. You might solve an infection for yourself, but it might lead to infections elsewhere because of the One Health agenda. So there's that sort of thing. There's also about antibiotic disposal. I think, for example, at the moment, we know that a lot of the antibiotics that we consume go straight through us. I mean, they work, but they're still going straight through us. Some of them are metabolized, some of them are not. So we need to be better at stopping antimicrobials, going down the sewer system. And getting out to the wider environment from us, because that's leading to increased resistance. The same with veterinary animals, really, just trying to reduce the prescribing doses where we don't need them, and we've been very successful at that in the UK. So that I think that initiative has really worked. What else have we been doing? Obviously education is a great thing to do, to just inform people about these things, to say that it's what you do now may not influence your next week, but it may influence 10 years down the line when you go into surgery. So I think it's putting that into place. And when you ask people about antimicrobial resistance, or AMR as we like to call it, many people still have no concept of really what that means. They've heard of the name, but they don't understand it. So there's clearly a role for education. There's certain elements of the community which need upskilling more. Certainly younger people need to be better educated in antimicrobial resistance. When we've surveyed people, it tends to be the older generations who are more clued up on it, for whatever reason. So we need to still educate certain sectors of society better, I think. And just tell them that this problem is only getting worse. It's not getting any better. Not that people like to hear bad news, right? But I think that there's the alternative approaches as well. There's a push in many countries to use phage therapy. So getting away from using antibiotics. We haven't really gone down that route here. Although there's lots of research in it now, and it looks really promising. We still don't know how quickly the bacteria or whatever will adapt to this phage therapy of being attacked by another source. Probably that will also turn out to be a warfare of trying to keep one step ahead.
Yeah. So these are bacteriophages. So these are viruses that infect bacteria, aren't they?
Yeah. So So there's that sort of element. There's there's this element of screening people when we go into hospitals. So do you know what you carry? Do I know what I carry? I have no idea what my gut microbiome is. I just hope it's a good one. So before you had an invasive surgery, for example, in some clinical settings they will test to see what resistant organisms you have in you as a sort of preloader, really, to say, if an infection does happen, we can treat you more quickly with the right antibiotics rather than putting you on a course, realizing that they don't work and whatever. So there's sort of that element is good. One of the other approaches is obviously to develop new ones, to keep finding, discovering. There's thousands and thousands of different bacteria and fungi living around the world, millions of species. So they all have these mechanisms. It's just trying to find, find those. And one of the issues that we have with antimicrobial resistance, I suppose, is that there's, of the little bit of DNA that confers resistance to the antibiotic. People often think antimicrobial resistance is one thing. It's like a thing, and it requires one solution. But there's about 20,000 different antimicrobial resistance genes.
Wow.
So that's a lot to target to, of which not all of them are a problem for us, but it shows you the big complexity of the problem. And at the moment, we've found those antimicrobial resistance genes in about 1,400 different pathogens. And different pathogens may have different ones because they live in different places. So it's not one size fits all. So for each of the pathogens, we may need a different strategy for different settings. So, anaerobic bacteria versus aerobic bacteria, or whatever it happens to be. So, that's an issue. I think we need to educate people better about the environment as well. Is that, we're trying to promote wild swimming at the moment. So the idea of going into the environment, the well-being factor is definitely a big plus. People are so, their mental well-being is much improved by being in contact with nature. But at the same time, they need to realize that, nature can be quite dangerous, and it could be the hidden things that you don't see. And particularly, where, there's lots of proven cases of people coming into contact with animal, waste, and contracting diseases. So those are, these pathogens that you have. So consequently, with those, there will be antimicrobial resistant organisms. Same thing with swimming. You're coming into contact with water that may be contaminated, and you may, get in contact with those things. And we know that, if you go, if you shower afterwards, you're basically washing these things off your skin. So I think there's things that people can do. Obviously, keep your mouth closed when you're swimming.
Don't put your head under.
Yeah. So breaststroke only. So it's, there are some things I think that we could do to inform people better. And there's bits of the food chain which we eat raw. I mean, oysters is something I always come back to because, there are so many cases of people getting sick from eating oysters, mainly from viruses. But, if you're taking in viruses, you're also taking in, bacteria and, probably those that are antimicrobial resistant. So, yeah, there's a need to show caution there, I think. And then we could have better surveillance, I think, as well. At the moment, we rely on sort of clinical data to basically tell us what's going on. So if somebody gets sick, we investigate it. We may isolate the organism. It might be easy to see what it is, to test for it. Sometimes they're new and emerging, and it takes sequencing, technology to find out what they are, these novel ones. But also, we're involved in wastewater-based surveillance. So, we collect all of the sewage from everybody in a community, and we analyze it, and we can see what antimicrobial resistant organisms are there. And we can see whether they're changing over time, whether those patterns are coming and going, and we can look at which organisms they're in. So basically, we take the sewage, we spin it down in the centrifuge, we collect the little pellet at the bottom, we send it off for sequencing in our lab. It tells you all of the organisms that are in that sample, thousands and thousands and thousands of them. But they're all in jigsaw pieces. We then put all the jigsaw pieces back together and find out which organisms are carrying which genes. And it's really powerful technology. And now we can use that to see, which organisms are moving from, we're based in Wales, from South Wales to North Wales, which organisms may be coming in with tourism from Liverpool or Manchester. And we monitor the wastewater from healthcare settings, from hospitals, you can do it from care homes, all of these, what we would call high-risk places. And so we've done that to basically match up what's happening in the community to see whether things are going from the community to the hospital or from the hospital to the community. You can start to track these things, but also you can measure what comes into the wastewater treatment plant. It tells you about everything about all the people who are connected to the sewer network, and everything that leaves the wastewater treatment plant tells you all about what people are going to be swimming in, or maybe, or animals maybe coming into contact with. So that's quite interesting. One of the pilots we've got at the moment is, how do we evaluate which antimicrobial resistance genes are in the animal population? So at the moment, what we do is we tend to go around and collect, cow pats or something, or, fecal swabs,
That's
rectal
not
swabs.
a glamorous job.
No, it's slightly less glamorous than wastewater testing at the sewage plant. But so you can go and swab the animals and what have you and test them. That's quite labour intensive, and it's very costly and time consuming. So we've got this new strategy now, is where we just go to the abattoir, where there's tens of thousands of animals all congregating in one day, and most of the organisms, the ones we're interested in, live in the guts of the animals. So as part of the slaughtering process, all of the gut contents, obviously gets disposed of, but we can sample that. This is even less glamorous now. So we can sample, the gut contents of those thousands of animals, all of which are coming in cohorts. So in theory, you can track which cohorts they're associated with to some extent. And, in one day, we can sample 10,000 cows or 100,000 chickens, or 20,000 pigs. So that's a really powerful way to see, so what's going on within the population. Of course, at the same time we're doing antimicrobial resistance, we're checking whether they, which porcine viruses the pigs might have or whatever. So, it's what we call one sample, many analyses, osmosis. So the idea is that you're not just checking for one thing; you get all of these things at the same time. So it's much more sort of powerful and useful. And one of my favourite ones is tracking people on aircraft. So for one of the things that we're quite interested in, in healthcare settings in the UK is, where do these organisms come from? How did they arrive here? And of course, as sort of preempted, a lot of it comes with people travelling from overseas. So you go on an overseas holiday. You can track something and you bring it back with you. Sometimes you recover and you don't need to go to the, to hospital or to the GP, but sometimes you do. And what we've realised now is that, when we've analysed, we know this from people coming back from holidays and the reports that go into the GPs, whatever. But when we've tested aircraft wastewater, so you particularly on a long haul flight. So if you come in from Australia, there's about, because we've done surveys with people, there's about a 40 to 50% chance that people will use the toilet to defecate on a flight, a long haul flight. And only 50% of people, most people will go for a wee, but, I think that's about 80 to 90%. But, most people, don't defecate on a short haul, but they will on a long haul. So we can collect that, analyse it, and see what's coming into the country. So that's also been really useful, because what we found is that there's antimicrobial resistance genes that we're bringing in, the new ones all the time into the country. So we've got this import rate which we never had previously. More people are travelling all the time by air. So we've got continual mixing, global mixing of all of these pathogens and the resistance genes. So we saw with COVID, people obviously started in Wuhan. People from Wuhan transported it around, got into Europe. Everybody went on their skiing holidays, brought COVID back and seeded it in little fires all around the UK, and off it went. And then we had the the pandemic. So we know from viruses that it happens, but we've never really monitored it for resistance genes. So now we know that planes are a big issue. And one of my other ones is that we've been monitoring some of the airports in the UK, and we get a long haul flight that lands. Somebody uses the toilet. Their waste goes to the wastewater treatment plant. There's a storm that day. We get bypassed through the sewage treatment plant, what we call a combined sewer overflow discharge, CSO, and then that goes straight out to the environment. So we can transfer a resistant organism all the way from Australia, all the way to coastal waters of the UK within less than 24 hours.
Wow.
You know, that is incredible. Yeah. So, you know, we talk about bits of, you know, flotsam and jetsam, plastic bottles or something floating around the ocean transporting pathogens, which takes months and months and months and months, you know, but yet we have millions of people just doing this every day of the week, and we've never really realized what the risk is. So surveillance at airports is also becoming an international initiative now, for antimicrobial resistance, but also for other, you know, a whole range of other dengue fever and all these other things that are now becoming more prevalent. So, yeah.
Wow. That is fascinating.
Yeah. So next time you go to the toilet on a flight, you'll think you're a citizen science contributing to the greater good. Yeah.
Wow. So, I mean, it is encouraging to hear that there's so many different ways that we're already trying to tackle this problem. And some of these things coincide with the work that you're doing at the Digital Health Hub for AMR. So I wonder if you can tell me a little bit more about that work.
Yeah. So the Digital Health Hub, you know, is a government-funded initiative to try and bring together, headed up by you know, UCL in London, to try and address this from this sort of what we call the One Health agenda. So trying to bring data streams together. So I think it's a good thing and a bad thing in many ways. In the olden days, we used to just plate out bacteria on agar plates and see which antibiotics they were resistant to. But now, of course, we have all of this technology that we're collecting data all the time from everybody, you know, whether it be from your mobile phone, which tells you, you know, where you've been and what you may come into contact to, you know, what you search for on the internet. I had diarrhea and vomiting, you know, or, you know, it might be clinical data, it might be environmental data. And it's coming from all veterinary data. It's coming from all these different data streams. And what we've realized now is that we're in data overload, you know, and no single person has the power to interpret that, you know, unfortunately. So it's about harnessing sort of some of these new machine learning tools that we have. You know, we talk about AI all the time now. It seems to be a sort of, you know, ever increasing sort of, you know, buzzword that everybody uses. In this case, what we're looking for is looking for connections between things. So we're using it to analyze very, you know, complicated data sets. I mean, they're not complicated in themselves. They're very simple. It's just that they've got, you know, millions of numbers in them. So all of the organisms that we have and which genes they carry, for example, and there'll be thousands of organisms and thousands of genes. And what we're trying to do is make connections between the different environmental, veterinary, clinical compartments, different places around the world, and see where the patterns lie, to try and understand, you know, the movement of pathogens from A to B, or the evolution of organisms. So E. coli picking up new resistance genes, for example, in our guts, or it might be, you know, linking to management practices and behaviour. So we have lots of this other data which we don't conventionally use for antimicrobial management. And it's, you know, it's seeing the patterns, seeing whether we can pick out anomalies. So it's what I like to think about it is that, you know, we measure antimicrobial resistance in wastewater. We see this pattern on this day, we see the same pattern the next day, the same pattern the next day, the same pattern the next day, and then all of a sudden there's a shift. And then we see another shift. And then we think, we can't pick that out ourselves by eye because there's too many numbers to look at. But the, you know, machine learning approaches can start learning what the patterns are. Can't really interpret them, but it can tell you when the pattern changes. And then we can go in and look for things. So, you know, we can then see if there's been changes in prescribing that we can link it back to, or whether it's an evolutionary pressure that's led to something new emergence of an organism. So there's those types of things. There's also obviously the drug discovery type stuff, you know, using supercomputers to design new drugs and what have you. So that's all getting data in and using it in new ways, really. But yeah, I mean, obviously data is power in this, and, you know, and it's really complicated. It's really annoying because, you know, on certain other organisms, the pathogens, viruses, for example, like, you know, SARS-CoV-2 that we've just been through the pandemic with, it was, in a way, we know it's evolving, but it's evolving in a very I'd say, in a sort of structured way to try and improve its infectivity to us. But it's a relatively simple problem to track. Whereas antimicrobial resistance, because it involves thousands of organisms and thousands of genes, makes it incredibly complicated. So that's why we need to have these sort of, machine learning things. But it's about understanding the problem and predicting and tracking. And then there's all sorts of, new devices. So harnessing, devices that we can use bedside, for example. So as patients come in, or, we can or literally evaluate them in real time. So equivalent to when we did an LFD test for SARS-CoV-2. We have devices now that you can literally do LFD tests for antimicrobial resistance. So it allows you to see which ones you carry, and then obviously you can target the drugs in a much more targeted way, and they're super quick. So within 30 minutes, say somebody came into A&E, within 30 minutes or less than that, you would have the answers to what they had. So that's really cool.
So that's the lateral flow. That's the swab up the nose, swab in the back of the throat, into the solution, onto the test. Is that that was that?
Yeah. So those I mean, they're slightly different in the way they operate, but because they're on a nanodiamond type platform, but which sounds more complicated than it is. But it's a great bit of science technology from UCL. And that is, that will change the way we do things there. But I think it's also about, understanding behaviour and data to understand behaviour. So, we know many of the issues that we have, some of it relates to the behaviour of people in healthcare settings. We have an issue about antimicrobial disposal at the moment from drips that we use, for giving into people. What do we do with the waste antibiotics from those? How do we treat them properly? And just understanding people's movements in hospital, whether they, if you could sterilize everybody, obviously an impossible task, and sterilize everything within the hospital, nobody would get an infection when they were in there. But that is never going to happen. On our skin, there's thousands of organisms. People are coming in all the time. And if you stand by the door, to the ward, and it says clearly in big letters, make sure you disinfect your hands before you go in, and lots of visitors never do that. So there's understanding those, and that's, it's also about data. It's understanding that and, seeing which interventions work best. If we want to communicate things to people as well, how do we best communicate? Sort of dashboard, you can look things up on the, on the web, and it'll tell you that this is going up and down and things. And people in the times of COVID would look at the dashboard and, if you were immunocompromised, for example, you'd make a decision about whether you were going in to town or not into town based on, what the risk was. But for antimicrobial resistance, we don't have that. And partly it's because we don't have the data so much, but it's also, how do we communicate that with somebody? And how would they take any notice of it? So, so we want to understand, if we start to put data out there to the general public, or we put it on a dashboard, or we send them things, do they look at it once, go, I have no idea what that means, or do they take notice of it? We've had some great examples in the times of COVID about how people interact with information, and I think it's opened our eyes to the fact that there are many issues about trying to change people's behaviour in a long-term setting. People will change something overnight, but then 3 days later they've gone back to normal. So it's I think that, and it's and the environmental side of things is a complete, nobody really thinks about that, and we need to have bring data. We need to bring that data together, which is what the hub is about, and then synthesize it into something that somebody may understand better, whether it even be a red, amber, green system for this water is safe, this water is not safe, these are the risks. And it might be risks of viral contraction, norovirus, or it might be antimicrobial resistance. So, we don't want to scare people off from, doing open water swimming, but I think, genuinely, I think that they should know what the risks are.
Yeah, absolutely. Like, knowledge is power, like you said earlier. Yeah, absolutely. Well, that's quite a task you have at the Digital Health Hub. So good luck. There's a lot to do.
Yeah.
Oh, Davey Jones, you've been brilliant. Thanks so much for coming and sharing your time this morning.
More than welcome. Thanks very much.
Huge thanks to Davey Jones for sharing insights into this challenge. Here are my reflections on our conversation. It's clear that growing antimicrobial resistance is a huge challenge. If left unchecked, we risk losing our weapons in the fight against bacterial infections. Davey described lots of ways that we can begin to tackle this problem. It starts with better understanding of the biological mechanisms of antimicrobial resistance and understanding what's going on that teeny tiny cellular level, and using this information to discover and develop new, better antibiotics. Tighter regulation on the use of antibiotics so that they're used properly for only bacterial infections and at doses that are enough to kill the bugs, but not so much that they pass straight through us and out into the environment. Better screening so that we know what type of infection a person or an animal has and what the best antibiotic to use would be. Better education into the use of antimicrobials in humans, animals and within the environment, and how and where they could be spread. And using data to understand the flow of these pathogens globally, how resistant pathogens are moving around the planet, and using this data to predict outbreaks and inform people of risks that might be in the environment. You can find out more about Davey and the work at the Digital Health Hub for AMR in the notes. Thanks so much for listening to the Digital Health Hubcast. I'll see you next time.